The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, good morning for some, and thank you for joining the RLS Foundation's webinar titled Medical Marijuana. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Bainbridge will answer as many questions as time allows after her presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the members-only section of our website. If you are not a Foundation member and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today, Dr. Jackie Bainbridge, serves as a clinical pharmacy specialist at the Ann Schultz Outpatient Pavilion in the Neurology Clinic and professor at the Skaggs School of Pharmacy and Pharmaceutical Sciences. This is part of the Neurology Residency Teaching Program at the University of Colorado in Denver. Services provided in these clinics include review of patient information, identifying and resolving drug-related problems and consultations, recommending alternative medication therapies for patients, evaluating patients for medication toxicity, providing cost-effective recommendations, providing education to healthcare practitioners, patients, and families, monitoring and reporting drug interaction. Dr. Bainbridge manages patients with neurological diseases such as epilepsy, Parkinson's disease, multiple sclerosis, migraine, and restless leg syndrome. Dr. Bainbridge is currently involved in a number of research projects funded by the NIH. I will now hand the presentation over to Dr. Bainbridge.
Thank you so much for that great introduction, Carla, and thank you, Chiara, for helping to put this presentation together. As mentioned, we are really going to focus on medical marijuana and more specifically its use in restless leg syndrome, which I'll abbreviate as RLS. Here's a little brief agenda of what we'll be discussing. We'll go through a brief introduction, some of the history of cannabinoids. We'll talk specifically about the components of cannabinoids, THC and CBD, and the difference between those agents. One tends to be more psychotropic and the other does not have psychotropic or that high tendency effect. We'll talk about different dosing forms, dosage forms. We'll talk about indications or recommendations for neurologic disorders as we have information about. We'll talk about short-term psychological or physical effects. We'll also talk about conditions that potentially may be treated or relieved symptomatology from. We'll talk about research or lack of, and we'll talk about the federal laws and guidelines. So just a brief introduction about restless leg syndrome, or RLS. We know it's really pretty common, mainly underdiagnosed, but is a treatable condition. Symptoms mostly consist with an annoying, painful sensation or motor type sensory effect, and everyone's a little bit different. Some people will just have the sensory component, some people will have a pain component with their RLS. Neurologic movement disorder is how RLS is categorized, so it's lumped under a sleep disorder. At the NIH, we're lumped under heart, lung, and blood for most research endeavors. We know the prevalence is anywhere from 3 to 15% in the general population. I think that's it might be slightly higher than that. I'm not sure. That's just the information that we have at this point in time. We know the incidence will increase with age, and women are more affected than men. Pregnancy, patients with who are pregnant, especially in the third trimester, will have symptoms of RLS in about 35% of the population. And really our diagnosis is mainly based on clinical symptomatology and features. Some of the descriptors, as I've talked a lot about RLS in different groups, and I collect how people describe their RLS. So some people will describe it as creepy, crawly feelings in their legs, heebie-jeebies, burning, searing legs, Jimmy legs, the gotta move legs, so that's going back to Elvis, or the Elvis legs. Some people will describe it as flowing water, or children oftentimes will talk about ants or bugs crawling up and down their legs, or just tugging or pulling kind of sensation. So I like collecting these because it really drives home how people present so differently across the board, and practitioners, we need to listen to those signs and symptoms that patients may describe as their RLS. Some non-medical therapies that really should be employed with medical therapies, and oftentimes we'll try these therapies initially and then continue through pharmacologic endeavors. So the first thing is obviously to have good sleep hygiene. So maybe change your sleep time, maybe consolidate sleep. And I know that sounds really like that's what everybody wants, but of course that's really important, and that's really our goal with sleep disorders. Moderate exercise is really important and really, really good. However, extreme exercise may be hazardous, or not hazardous, but may exacerbate RLS. Massage is excellent. Baths, hot or cold packs, any type of stretching or rubbing or pressure, and also meditation exercises or yoga. Anytime you're engaging the brain, you may actually bypass some of the symptomatology of RLS. Acupuncture can be helpful in some individuals. If you have low iron or iron deficiency, that should be treated to relieve the symptomatology, and iron is, for the most part, an over-the-counter medication unless you're receiving IV iron therapy. And then eliminate medications that can exacerbate RLS symptoms. When we move to medication therapy, really the hallmark, or probably the first place that we should go for therapy, in addition to non-pharmacologic therapies, would be the alpha-2 delta ligand. So those medications would be medications such as gabapentin and acarbil, or Horizon. So this medication actually has an FDA labeled indication for restless leg syndrome. Also useful would be gabapentin, because it's very similar to Horizon, and you wouldn't want to use both of those medications together. Pregabalin also can be helpful. Pregabalin is more potent than gabapentin. However, it's a scheduled medication, so it requires a more frequent prescription. Dopaminergic agents also can be very helpful, but we just have to be careful that we're not inducing augmentation. Benzodiazepines can be helpful in some individuals. Opioids, in particular methadone, may be helpful for some people with more severe RLS. Iron therapy, levodopa, carbidopa can be helpful for some individuals, but again, we have to worry about augmentation. Other agents that also may be helpful are anti-epileptic drugs, or AEDs, cannabis or marijuana, etc. There are many others. So if you look back at history, when you look at the 19th century, marijuana was legally grown and utilized in the United States. Moving into the 20th century, in 1937, the Marijuana Tax Act was passed, prohibiting the use of cannabis on a federal level. In 1970, the Controlled Substance Act was passed, and it prohibiting cannabis federally, making marijuana a Schedule I drug. And it remains a Schedule I drug, so therefore federally illegal. In the 21st century, so now moving into our day and age, in 2014, the United States House of Representatives passed a bill prohibiting the DEA from using funds to arrest medical cannabis patients in states with medical cannabis laws. So if you were carrying a card that stated you needed the medical marijuana, it was okay to have X amount. And every state is a little bit different with those laws. So it's really important to pay attention to your state to find out what the quantity limit is and what type of laws are on a state initiative employed. At present, many states have decriminalized or legalized the medical and or recreational use of marijuana. And living in Colorado, we know that we have both medical marijuana, which we had for a few years prior to legalizing marijuana. When we move on, really when we talk about all the types of marijuana, it's really cannabinoids that we're talking about. However, there are two main types of marijuana or cannabinoids. So there's sativa and indica, and there's no documented information on this, but many people feel that with indica, it may be helpful for people who have pain or just a general achy feeling all over their body, whereas sativa may not be as useful for that achy, like all over pain sensation. So now when we talk about the major types, the cannabis sativa is predominantly THC, and the cannabis indica is actually both a blend of THC and CBD. So it may be for people who have pain components or sensory components that the indica might be actually a little bit better for those individuals, and I would actually toss potentially RLS under that group. There are also many hybrids as well, and there's continuous hybrids that are popping up on the market as we see them in Colorado. So now when we look at the cannabinoids, cannabidiol is CBD, so a little bit different. Remember, cannabinoids is just the big overarching title for the cannabis components in marijuana. So cannabidiol or CBD has no psychotropic effects. So it will not, people will not have the high effect overall. The mechanism of action is somewhat unknown. I mean, there are hypotheses and theories of where it binds and how it activates and interplays with the endocannabinoid system in the body, maybe even mimicking some opioid effects. But it probably does not bind, or it does not bind actually, to the CBD1 receptor as you would think it might, but it does not do that. And then when you look at delta-9 tetrahydrocannabinol, or THC, there is a psychotropic effect. So people will experience the high component with THC, and that's the main difference really between, or one of the differences between THC and CBD. And the mechanism of action of THC is that it's a partial CBD1 agonist, or receptor CB1 agonist. We do know that there are potential drug interactions that can occur with the cannabinoids, because cannabinoids as a group of chemicals, it's very diverse, structurally diverse chemicals. So when you look at cannabis sativa, there's actually about 500 known constituents, 70 of which are cannabinoids, and the remainder are potentially neuroactive substances, such as ketones or aldehydes that cross the blood-brain barrier and may be harmful to some individuals. When you look at the exogenous cannabinoids that are widely consumed, we find it in many, many forms. So the cannabinoid-rich preparations of cannabis, the herb, or what we think of as marijuana, the plant structure or resin form. We also have cannabinoid containing pharmaceutical products, either containing natural cannabis extracts, and we actually have two products, Sativex and Epidiolex, both made by the same company, GW Pharmaceutics, out of the UK. And both of these drugs are actually in clinical trials right now. Epidiolex, as the name implies, it's for epilepsy, and Sativex is actually very useful for multiple sclerosis type spasms and pain components. And then there are synthetic cannabinoids, such as dronabinol and a tetrahydrocannabinol, THC, or nabilone. What we find with some of these synthetic products, especially the ones that are commercially available, is that the THC component actually undergoes a high first pass metabolism in the liver. So your liver chews up the THC rather quickly, and that's why you might not see the same effects, such as with Marinol, which is a commercially available product and has been on the market for a number of years, but it's mainly the THC in Marinol. Now, getting back to the fact that there might be potential drug interactions, and some of these interactions have been documented, but there's not been a lot of pharmacokinetic or pharmacodynamic work on these compounds. But more information will be coming available hopefully soon. So pharmacokinetics, really we're looking at how the body affects the drug. How does our natural liver or kidney, how our system affects the drug in the long run. Pharmacodynamics is really when we're talking about the drug going to the spot of action. And we might see additive effects with other medications, which we specifically will see with cannabidiol. And we'll talk a little bit about that. And why would we see some of these drug interactions? Well, we know that cannabidiol is highly lipophilic, which means it likes to sink into your fat cells. And so it's going to stay in the body for a long period of time. Remember, our brain is a big fat organ, so it's going to be absorbed into fatty tissue very quickly and to a large extent. Then we know that there's also a high volume of distribution, so it distributes pretty much everywhere, and it's highly protein bound, which also means that if you have another drug on board, such as phenytoin or valproic acid, so Dilantin or Depakote, those drugs are highly protein bound, and so you might see that they compete, the cannabidiol or CBD may compete for that protein binding site, and you may see more of an effect with the cannabidiol or the anti-epileptic drug that you're taking, such as Depakote or Dilantin. We also know that cannabidiol, right, or CBD, is extensively metabolized by the liver. So it actually affects some of the liver metabolizing enzymes, the cytochrome P450 system, or CYP P450, 3A, 2, and 4, and 2C, 8, 9, and 19. So really, most of our drug interactions that occur with cytochrome P450, 3A4, and 2C9 interactions. So we know that there are going to be some drug interactions with cannabidiol or CBD and other medications, and specifically you would want to talk to your pharmacist about those interactions, or your physician if they're familiar with dealing with drug-drug interactions. But that might be a time that you would actually want to talk to your pharmacist about those specific interactions. The half-life of CBD is variable. If you look in the literature, you can find anywhere from 18 to 32 hours. So what that means is if it's a 20-hour half-life, it's going to take 20 hours for half of the drug to be gone, and so forth. So more on drug-drug interactions, and I bring drug-drug interactions up because there's a lot that we do not know about cannabidiol or THC, or the cannabinoids in general, in terms of interacting with traditional medications. Again, there is research going on to try and tease some of this interaction pieces out, but we don't have a lot of the information at this point in time. So we do know that CBD is a potent inhibitor of the 2C and 3A enzymes in the liver, which means that serum concentrations of other drugs may be increased. So you could see toxicity of other drugs that you're taking that utilize the cytochrome P450 system 2C and it's 8 or 9 or 3A4 for metabolism. So you could see a bump in your serum concentrations of other drugs. Again, this is a good time to talk to your pharmacist about the interaction piece. And we know with chronic administration of CBD, it may induce 2B cytochrome P450 isoenzymes, and that would be 1 and 6 in animal models. So, and we actually have seen this in the human model using people using clobazam. So basically what happened is that your patients were taking CBD and they induced or chewed up faster the clobazam, which is a benzodiazepine that is FDA approved for certain types of epilepsy. We also know that it induces valproate or Depakote. So I mentioned Depakote a little bit earlier. It's highly protein bound. So you're actually going to see two different types of interactions with the Depakote, either being a highly protein bound interaction, so you don't know which drug is going to win out when you're competing for those protein binding sites. But we also know that the CBD, if you're taking it on a regular basis, so chronic administration, will induce those enzymes, so you'll decrease your serum concentration of valproate, or Depakote is the generic name, or the brand name for valproate. Other drugs also can affect either CBD, so the cannabidiol, or CBN, which is cannabinol, or THC, which is the psychoactive component. And I have some of those specific cytochrome P450 system isoenzymes listed below for you. Now, there are many different forms of marijuana. There's what we typically think of as the leaf or the plant product, which can be smoked, or in Colorado we have edibles. And then we can vaporize it, which by vaporizing it, you actually get the fastest amount into your bloodstream in your brain, and you also decrease some of the carbon products. So it's a little safer than just smoking it. We'll talk a little bit more about that in a couple slides. You can also you can eat the plant, the resin from the product, or it can be smoked. There are oil extracts such as nabiximols, which is Sativex, and you specifically will find that in that MS preparation that GW Pharmaceutics is developing and is in phase 3 clinical trials. So we're expecting that hopefully on the market sometime, in the near future. And then Candor also. There also are single molecule preparations that have THC in it. Specifically, dronabinol and Marinol we've had on the market as a commercially available product. So they're completely synthetic, but they actually undergo a high first pass metabolism because of that THC component. And it's pure THC, really. Chemical variations of THC are Nabilone. And then there are liquid formulations. So Epidiolex, the product that GW Pharmaceutics is actually developing, is a liquid formulation, and it's pure CBD that's used for the treatment of pediatric epilepsy, and it is in stage 3 or phase 3 clinical trials. Now, I mentioned, with these different forms, we can either ingest it orally, as on the right side of the screen. Your Cmax is your maximum serum concentration. So when you ingest it orally, and it really depends specifically on the product that you're looking at, but you can get your maximum serum concentration in about 1 to 3 hours. F means how bioavailable it is. So how readily available is it to distribute in your body and get into your system, your bloodstream, and your fat cells. And you can see that oral administration or ingestion is about 5 to 20%. But if you look over on the left-hand side, if you're inhaling or smoking marijuana, then you actually will get more of it into your system quicker. The duration of oral ingestion is about 4 to 10 hours, whereas if you're looking at the smoked or inhaled formulation, it's about 1 to 4 hours. The half-life is about 19 hours when we're talking about the smoked or inhaled formulation, but it's much longer with the oral administration, up to seven days. And remember, that's the amount of time it will take for half of the product to be active or in your system. Now, going back over to the inhaled side or smoked side, your Cmax, or your maximum serum concentration, is really pretty quick. It's 3 to 10 minutes on that side of the screen, as opposed to the oral administration, which is 1 to 3 hours. And these are on this slide, you'll see the different preparations. You'll see the dried flower buds. You can actually make a butter with the infused marijuana. You can see that there's hashish, there's tinctures, there's pipe resin, and that really strange thing on the bottom slide, I mean hash oil, you see that, but there's a vaporizer. So that vaporizer has an electronic start, so you're not using any combustible materials, which is better for people, so you have the electronic start, and you load these little balloons with the marijuana, and you have a detachable balloon. So you fill that balloon with the vapor, and then the person inhales from that balloon. And that's what we call a vaporizer. So a lot of our clinical trials are actually using vaporizers because you don't have the combustible materials, which are safer for people. The vaporizer, however, is really super expensive. I don't know, you can get them on the market. Some are $500, some are $1,000. And I like this little slide about marijuana consumption because it talks about how people are ingesting it. So they're either eating it, vaporizing it, or smoking it. So if people are eating it, they're swallowing the herb as it is, or extracted with fat or alcohol after decarboxylation. It's extracted with fat, meaning made of butter or for the purposes of baking. And then extracting with alcohol causes the THC or CBD oil, hence creating a liquid of the active ingredients of the marijuana. So the temperature will start at about 80 degrees C or 160 or 76 degrees Fahrenheit, and that allows for more of the 11-hydroxyl THC present this way, which is stronger than the THC by itself. So you get your effects about 60 minutes after ingesting, which will last about 4 to 8 hours. And then vaporizing, you're heating the herb before it burns, or other forms of cannabis, such as hash or concentrates, using a specific vaporizer. So the temperature really starts at about 157 degrees C or 350 degrees Fahrenheit. So the goal of using the vaporizer is to decrease the potential carcinogenic effects of burning or smoking the burnt leaves. So you create the vapor at the right temperature, and the effects last about 10 minutes, or you start to see effects about after 10 minutes, some people a little bit sooner, and last for about 2 to 3 hours. And then smoking, the burning of the herb or other forms of cannabis, such as hash or concentrates, the temperature starts at 800 degrees C or 1470 degrees Fahrenheit. So potential for inhaling carcinogens because of the temperature creates a smoke. You will get your initial effects about 10 minutes after ingestion, but that will last about 2 to 3 hours. So it's kind of interesting, and I think people need to keep this in mind when ingesting these products. So if you're looking at the potency for neurologic disorders, you know, everybody is a little bit different, and we need to think of people as being individual. So more personalized or individualized medicine or therapy, because everyone's tolerance, again, metabolism, other medications you're on, really need to be taken into account when you're starting to take any of these types of products, marijuana, or actually any medication in general. And the older we get, the more medications patients are going to be on, so there's the potential for more drug-drug interactions. Changing doses of marijuana really should be based on the therapeutic response of everyone individually. If you look at the short-term physical effects of marijuana, we know that people will have dry mouths, potentially decreased intraocular pressure in their eyes, reddening of their eyes. When you look at their skin, they may have different effects to heat and cold or sensation. You can actually have an increased heart rate, and we do know, and this could be beneficial for many people, is that their muscles tend to relax. So conditions in which marijuana may be appropriate would be patients with pain, for pain therapy, or in conjunction with some of their traditional pain medications. People who have sleep issues or potentially RLS, even anxiety. However, there are many reports and studies that actually show that marijuana will induce anxiety in patients. It's actually used in cancer patients for chemotherapy-induced nausea and vomiting. However, interestingly enough, there is the least amount of literature out there in this group of patients. It can be used in patients who have cachexia, so you're going to increase their appetite, hopefully putting more weight on them. You can also see it maybe being beneficial for patients with glaucoma, decreasing intraocular pressure. We know that it is helpful in multiple sclerosis because it releases and relieves spasticity of the muscles. That also may be effective for patients with cerebral palsy or neurodegenerative effects, and may be useful in some patients with epilepsy. Although I will say the epilepsy, the jury's still out, because some patients have a good effect and some patients have either a worsening effect or no effect at all. So again, might depend on the product and the severity and type of epilepsy. Research is lacking. We're trying to get much research off and running here at the University of Colorado. However, it's really hard to get funding. I will tell you, it's creating many gray hairs on my head at this point. The reason it's so difficult to get a lot of research going is because it's still federally illegal. So which means if you're in an institution where you're getting federal funding for any grants, such as NIH grants, etc., you cannot do research on a federally illegal drug. We're trying to get around this particular legislation, but I'm just telling you, it's very difficult to do. So we currently have to go on what patients tell us. Now, we can do observational research. Observational research is basically when our patients come into the clinic and they tell us this is what they're taking. However, we don't know exactly, for most of those products, what's exactly in what they're taking, and we just have to take their word and the word of the manufacturer, wherever they're getting these products, to do some of the research. So private entities in the United States are beginning to conduct marijuana-based research to gain a better understanding of the medicinal properties. So again, major problem, in the United States is there are standardizations that are not adhered to in this market for these preparations. So we're trying to overcome it. When you look specifically at RLS and research, we really have to kind of go back and look at pain studies that have been done and sleep studies when we're talking about marijuana to really kind of gauge how patients with RLS may be affected. So there are no current studies that have specifically been done in a really nice, rigorous study using marijuana and RLS. When you look at the research that has been done, cannabinoids for the treatment of chronic non-cancer pain, so again it's pain, and this was a systematic review of randomized trials. So this is all the trials that were kind of done, pulled together. There were 18 trials. The formulations consisted of smoked or an extract, mainly THC or nabilone, and other unique molecules. And 15 of the 18 patients reported improvement in pain, and 4 of 18 reported an improvement in sleep. A limitation to the study is that the duration of the studies were very, very short, and there's not very many, it's not a standardized product that was used throughout those particular products. So it can be assumed that from these studies that cannabis decreased the pain, therefore allowing some patients to get better quality of sleep. However, they did not really discuss the duration of which the patient's pain was not present or how much the pain improved, so across the board in all of the studies. And then again, the systematic review meta-analysis in chronic pain, 18 trials. This was looking at double-blind randomized controlled trials, which is really the hallmark for good research, and it compared cannabis preparations to placebo amongst patients with chronic pain. The study showed that cannabis does yield moderate effects for the treatment of chronic pain. However, they recommend that a study be done clarifying the benefits, risk of the benefits and harms. Again, pain and sleep research, smoked cannabis for chronic neuropathic pain, so, specific to neuropathic pain, which some patients may fall under with RLS or similar type pain to RLS and neuropathic pain for some people. Randomized controlled trial, adults with neuropathic pain were randomized to receive either cannabis at 4 potencies, 0, 2.5, 6, or 9.4 of THC for 14 days. They crossed over. Daily average pain was measured using an 11-point Likert scale. So did you have pain, did you not? The study indicated that a single inhalation of 25 milligrams of 0.4% THC 3 times a day for 5 days significantly reduced the intensity of pain, improved the quality of sleep. However, you have to go back and look at the overall effects on pain and sleep, and was that minimal or not. Also in the sleep world, the effects of cannabinoid administration on sleep, a systemic review of human studies, 39 clinical trials. Formulation consisted of smoke, THC, nabilone, Candor, nabiximols, or other oral formulations. The information provided did really not allow for strong clinical decisions to be made because the studies featured many different conditions and formulations. It's really pretty important to have consistencies in clinical trials, but since most of these trials were done retrospectively, potentially, or not consistently done across the board of those trials that were done prospectively, it's hard to compare apples to apples when you're really looking at apples to oranges. So the study results were really mixed, but nonetheless showed that cannabis does affect sleep. Some studies had strong biases, indicating the need for a study to be conducted on specific effects of cannabinoids in regards to sleep. So again, the observation was that the use of cannabis with a condition that disrupts sleep may result in a decrease in nighttime interruptions and improved quality of sleep. But more rigorous research needs to be done, hence this next slide. More studies need to be done to assist in the proper use of cannabis for RLS. Federally, marijuana is a Schedule I drug under Federal Controlled Substance Act, making possession, usage, purchase, sale, and or cultivation of marijuana illegal. So crude marijuana may not be prescribed, administered, or dispensed under federal law. Now, every state has their own set of laws, but federal law really trumps state laws. So therefore, it's really a bad idea to come to Colorado, decide that you're going to take a bunch of marijuana over the border, because it is now a federal offense, because it's a Schedule I drug. Other Schedule I drugs include LSD, heroin, gamma hydroxybutyric acid, or GHB, MDMA, ecstasy, and mescaline. This is basically a nice slide of the United States where you can see that there's adult use and medical use in the dark green. As you notice, we have Colorado highlighted there, and only a few or a handful of other places you will see adult and medical use. Cannabidiol only in the lighter green or very faint green, lime green almost, states, and then medical marijuana only is in the medium type green, I guess, and you can see that there are more states as opposed to the adult, recreation, and medical use. And then there are a handful of states that actually have no laws regarding marijuana. As you notice that many of those states that have no laws are really kind of nestled up next to the states that have both recreational and medicinal marijuana. So again, bad idea to go across the border. Guidelines. The American Academy of Neurology, or AAN, really endorses the use of cannabis for the treatment of the following disease states. Symptoms of multiple sclerosis that can actually be spasticity or painful spasticity, some pain components, even some bladder type symptoms. Uncontrolled movements of Parkinson's disease, motor symptoms in Huntington's, tics with Tourette syndrome, cervical dystonia, and abnormal neck movements. Mainly that can be related back to Huntington's disease, and some individuals with severe epilepsy, so seizures and epilepsy. Really, the strongest evidence for use of oral cannabis extract pills from pure CBD to lessen patients' spasticity, and moderate evidence for THC pills and the oral spray to lessen spasticity and painful spasms. And that's mainly, we're talking about some of the GW preparations. So some of the frequently asked questions that come up on a regular basis to the foundation is, how can I get medical marijuana in my state, or what doctor prescribes it? And you really have to be very careful to look at what state you're in and the laws that pertain to medical marijuana and or the use of recreational marijuana. So and in the case of medical marijuana, it's legal for the doctor to give you a medical marijuana card. So they'll fill out the paperwork necessary and do the proper documentation, and then you have to take that medical marijuana card to have it be registered at specific dispensaries. And again, it's going to work a little bit different in every individual state. So if you're in a state in which recreational marijuana is legal, but your intentions are to use it for medical purposes, you still have to consult with your provider. It's really important to let your practitioner know if you're ingesting marijuana either for recreation or medicinal purposes, because we did talk about the drug-drug interactions that can actually be occurring. So it's important to have that discussion with your healthcare practitioner and your pharmacist. And now your pharmacist is now just written into legislation as a provider, which is kind of cool. So does cannabis-based oils do anything? Well, according to the studies that we've reviewed, potentially, and everyone's a little bit different in who it's actually going to work better for. So one of the randomized placebo-controlled double-blind trials, which parallel grouped of THC and CBD spray in peripheral neuropathic pain treatment, did show that there were improvements in pain and quality of sleep, but it did not reach statistical significance. So in a trial like this, we would say it may be clinically significant, but not statistically significant. So again, every patient's a little different, and you have to really go back and look and treat the patient individually and be treated individually. So is marijuana effective in treating RLS? Unsure, really, because of the lack of evidence. So practitioners always go back to evidence-based medicine for the most part. So we really need more studies specifically addressing marijuana in RLS and focus on sleep and pain to really assist in making those clinical decisions. It may be effective in treating RLS, but more studies, again, are needed. So how can you look for these studies? I would go online and I would look at clinicaltrials.gov. All clinical trials, larger clinical trials should be listed on clinicaltrials.gov, and it really depends on where they're getting their funding, but that's where you're going to find most of your reputable larger trials. We're trying to study it here at the University of Colorado, so don't hold your breath because you might turn blue, but we are working towards getting a clinical trial up and running here. So is there research being done? No, not currently, or it's very small in nature in RLS and marijuana. So basically, this is Jacqueline Bainbridge, and I have no conflicts of interest. And as a disclaimer, no studies have documented the benefits of medical marijuana for treating RLS, and its use remains illegal under federal law. Very important to keep in mind. It's important to speak to your healthcare provider before making any changes to your treatment regimen and take into consideration the legal status of marijuana in your jurisdiction. So again, in your state, because it can be very different in your specific states. So anyhow, again, I hope to get a trial up and running here at the University of Colorado. We are awaiting my federal DEA 1 license to come through, so keep your fingers crossed, because we have 3 trials on the line, 1 in neuropathic pain, 1 in tremor for Parkinson's disease, and then my specific trial will look at the efficacy and toxicities in RLS. So at this point in time, I've got a whole list of questions that I can run through, or I'll, ask if Carla, if you have anything you'd like to interject at this point in time, or Kiara, before I start going through some of these questions, frequently asked questions.
Well, what I'll do, Jackie, is I'll go ahead and ask you the questions, because I know we have about 10 minutes left on the webinar, and we have some repeats in the question. We got a lot of great questions, and I thank everyone for submitting with their registration. So I'll go ahead and start, and I will ask you, and you can answer. So the first question is, how can a patient use medical marijuana without becoming addicted?
So when you look at the addiction properties of medical marijuana, you really find that it's might be psychologically addictive, but really not physically addictive. So we don't really kind of think of marijuana as like heroin or coke or an opioid type thing. So it's more of that psychological type addiction. So it's a little bit different, and I guess less is more, consistency, and knowing what product you actually are getting and what's in your preparation.
Right. This was a very popular question, so I'm going to hop on over to this one. It says, can you get augmentation with medical marijuana use?
Well, so, we don't know. There's been no There has been nothing documented. However, I will tell you that I have spoken with a few people, so anecdotally I can tell you that they had kind of a wearing off effect of the preparation they were taking. Now that's just a handful of people. Now other people tell me that they haven't had that effect, but maybe they changed their regimen up a little bit, because depending on where you're receiving your product from, you can actually vary the amount of CBD and THC and use different ratios. So oftentimes tweaking those ratios, and I'm thinking, but I don't know for sure because I have no evidence, that maybe the combination product, THC and CBD, in some formulation, varying formulation or ratio, may be the better way to go in RLS, but I don't know. So I don't know about augmentation, specifically augmentation. I have not heard that anecdotally, but I have heard of a tolerance or a lack of efficacy or wearing off effect. But I don't know about true augmentation at this point because we have no studies.
Next question. Have RLS patients found medical marijuana to be more effective in preventing symptoms or abating them once they've begun?
So really, again, we don't have that evidence-based information, but what I've heard anecdotally is patients prevent it. So key to most of our medications for many of our patients with more severe RLS is really stopping it from happening, so stopping that fire from spreading or getting bigger. So the people that I've spoken to and they have had severe RLS have found it easier to take on a regular basis, like you would take any other medication, 2 times a day, once a day, 3 times a day, depending on the severity and symptomatology of their RLS.
Okay. Let me switch pages. Can smoking it harm our lungs?
That's a great question, and yes, it can, and that's why we're recommending patients do more of a vaporizer as opposed to smoking it other ways where you have combustible materials. We're not even, in our clinical trials that we have, we're trying to get running here at the University of Colorado, we're not even allowed to have patients smoke it. We have to only vaporize it. And we have a specific room that was just built out for the vaporization. So it is harmful to your lungs because of the combustibles.
Okay, next question. I've heard that medical marijuana has a stimulative effect on some people. Might it keep me awake even though it helps my RLS symptoms?
So that's more directed at the THC component as opposed to the CBD component. So you actually can see more of that stimulation, even that anxiety component, more so with the THC as opposed to the CBD. So yes.
Okay. What is known about the effects of CBD oil from hemp on the treatment of RLS?
We don't know at this point in time. However, CBD, for the most part, if you look closely at how much THC is in that particular product, many of those products could potentially classify as a hemp with the CBD. So it depends on the amount of THC in the CBD component as to whether or not it can be called hemp or not. We've tried to go with this angle here at the University of Colorado in our clinical trials, but no one is buying it. So we don't really know exactly if you just went out and purchased hemp from Whole Foods, if that's going to have any effect or not on RLS, because it hasn't really been studied, and I've not talked to one person who has done that.
Okay. Might medical marijuana be helpful for PLMs?
Potentially, but again, potentially it is, but we're not exactly sure.
Okay.
Excuse me.
Bless you. What what are the effects of medical marijuana on sleep architecture?
The effects vary on, but it looks in the clinical trials that we do have, or those randomized studies, those meta-analysis, so looking at those, pulling all those different studies together, those even the systematic reviews, you actually see that it looks like it might be pretty good. So favorable.
Okay. How large is the risk of developing a tolerance or augmentation to marijuana?
Well, again, we don't exactly know. However, I have spoken to people who have had a tolerance effect. I have no idea about augmentation. No one has reported that I've spoken to. I've not seen that, in the literature, but I think it's definitely something that we should pull and look at retrospectively and prospectively to try and get something in the literature about that. It's an interesting question. I definitely think that you can see the tolerance. The people that I was speaking with, though, I don't know if they were just doing a pure CBD, and maybe that's not the best product, or it might be a good product for some people, not other people. It might be, and these are all questions that we're going to try and answer with our study, if the THC CBD blend is really the better way to go, and I have no idea about the ratio between those two.
Okay, next question is, Charlotte's Web oil is very popular here and is being researched more. Do you think it would be good for RLS?
So that's going to be a CBD product. That's specifically the one that we were hoping that the university would allow us to count as hemp. So I don't know yet. I think that it's possible, but that's going to be more of your CBD as opposed to more of a blend with THC and CBD. It's more heavily CBD. So it could work. I don't know.
Okay, we're heading up on the hour, so this will be our last question, and you've touched on it briefly, but I always like to, I'm always interested in research, as most people know or maybe don't know. I have a daughter that has restless leg, and that's how I entered into this in the early 2000s in my family. But the question is, what research is in the works, proposed or possibly submitted to the RLS Foundation for funding medical marijuana and RLS? And I take it out as far as what is going on nationally, internationally as well. What research do we see in the field for medical marijuana with and/or RLS?
So I'm not sure so much internationally, and you could maybe even speak to that if you know of something that's happening in Europe specifically for RLS. However, I know that we're thinking about looking at retrospectively through large databases, if we can find some reports, but we're also looking here at the University of Colorado. We may extend out to other centers once we can get our first study approved. Here looking at different components, so CBD, and THC, and maybe a placebo arm crossing everyone over, but that would be here at the University of Colorado and potentially pulling in one or two other sites if we can get a consistent product across the line. So that's what it's going to depend on. So there's not a lot going on out there, but hopefully ours will be the first big study that comes through.
Right, and we haven't, and to answer the question, to date we haven't had anyone submit anything to the foundation. So to answer this individual's question.
Great, thank you very much.
Great, and this was a great webinar. We had a fantastic outpouring of interest, and so I think this was just, this is a hot topic in the U.S., and I think it was great to have you present on it, to give us some background information, and to let people be informed about the product and what's going on, and to remember that it is illegal federally, not to cross state lines with it, and to always talk to your healthcare provider before making any changes in your treatment plan. So I want to thank Jackie for presenting and for all of you who joined us on the webinar today.
Yes, thank you very much.
All right.